Dr. Nordchasm, same question. For those who don't know you, and I'd be surprised if nobody knows you, tell us yours and Amy's story briefly as you can. I know it's not that easy.
Well, Sharon, thanks very much for organizing this first, both to you and to Kyle. So I wanted to echo what Kyle, before I sort of go into that, is echo what Kyle mentioned, which is that this film actually would not have been possible without Dr. Tom Floyd, who is Kyle's father and was one of Amy's mentors at Penn, really bringing this up to his attention. I mean, we certainly had no connectivity to the filmmaking world at all, and so with Kyle's introduction into the picture, he really started to archive and document the entire catastrophe. And so I'm very thankful to Dr. Floyd for making this introduction, and also I think the documentary probably speaks for itself in terms of the level of detail that Kyle has been able to capture and simplify for folks. So Kyle, thanks very much for this. This is really an important piece of work certainly for my family, but I think for the community at large. So I'm sorry, Sharon, the original question that you posed was what again? Can you
of your story, yours and Amy's story?
Yeah, so I think unfortunately it was one of these scenarios where we trusted the system that we belonged to, and ultimately we sort of discovered that our family fell into this really disastrous standard routine that gynecologists were exercising, which was essentially based on this incorrect assumption about uterine fibroids, which is that these are benign tumors, which I think it's statistically you can say that uterine fibroid tumors are benign for the most part, but I think as we know now, somewhere around 1 in 350 women with symptomatic uterine fibroids do not have benign tumors. And so this sort of was another example of an incorrect assumption leading to disaster. I think, it's sort of in our society, it's sort of, it's become emblematic of systemic catastrophes where we have problems that affect only a minority subset of people, and that somehow we're able to sort of tolerate the harm to minority subsets of people. And this is one example of that. I mean, you have one out of 350 people falling through a crack and being subject to disaster. And as long as the majority benefit and there's some sort of economic benefit in it, the system's willing to tolerate it. So.
Okay. Kyle, what was your biggest challenge in making this film? Two-part question. And what were your greatest rewards?
Well, I think, I'll kind of split the challenge into two. One of the biggest challenges was making sure that I had representation from both sides of the issue. I think that was probably the biggest thing. It was very long, arduous task to make sure I got the gynecologic side involved in this film. I didn't want it to be this straight advocacy film that people would look at immediately and think, oh, this is going to have no nuance. It's going to be completely one side of the coin here. So I needed a physician who was, pro morcellator, and I needed some physicians who were kind of the middle of the ground there, who could talk about both sides of the issue. So that was the most difficult part of it. I mean, there were so many reasons why people wouldn't participate. Either they were, again, pro morcellator. They were afraid what the documentary would, I guess, do to their image. Furthermore, there were a number of doctors who I got in touch with who were very interested in speaking with me about this, who were on the other side of the issue, and their hospitals would not let them speak. Mm-hmm. So you had that issue of kind of protectionism for a number of doctors, even at my alma mater, Boston University, where I think I had 3 or 4 additional physicians who wouldn't they weren't allowed to speak because of their hospital. But I think that limited it significantly, just the legal concerns of individuals, legal concerns of doctors who were wrapped up in litigation, whether it was at Brigham Women's Hospital or North Carolina or Duke or wherever. So that was the biggest thing. And I think the second biggest challenge, Sharon, was, again, making sure that I was communicating all of this information clearly to the average person, the lay person, and making sure that the film didn't get too bogged down in the medical jargon, and making it, continuously dramatic. It's over a 2-hour film, so it's quite a lot to go through, especially with the shrinking attention spans nowadays. So presenting it in a way that people could both understand and follow throughout the film, I think, was the biggest thing for me, knowing when to include enough detail and also not too much detail to keep people engaged. And then what was the most rewarding? I think just as a young documentary filmmaker, just the challenge and all the lessons that I learned making the film, having to tackle such a complicated issue as my first feature film. I think that was, a massive challenge, but also I just learned so many lessons throughout that process. I feel like it'll be a while before I find a subject that is more difficult to to make a film about than this, more challenging.
I agree. You did a fantastic job. It was a lot, and it was a long story, but you got every piece of it. So kudos to you for that.
Thank you.
So Dr. Norchasm, in 2014, the FDA, after the FDA testimonies by you, Amy, Sarah, myself, and other patients and families, the FDA issued a black box warning on the morcellator instead of banning it. What caused the FDA to fall short of issuing a ban?
So that's a great question, and yeah, that the July 10th and 11th, 2014 hearing was really sort of a turning point in the whole fight, and really it was an effort on the part of the whole community. You recall, many members of the LMSDR community were there, and we all sort of strategized together. The press was involved, and I think it was a big fight because that whole. Oh, hi, Sarah.
You got Sarah.
Sarah's here, but she's muted.
How are you?
She's muted. Hang on.
She's muted.
I'll unmute her.
Unmuted. Let's get her unmuted. I don't see her. Got it, Kyle?
Yep. I think I just have to ask her to unmute here. There we are.
Oh, there we are. Okay. So we're just talking about the FDA hearing, Sarah, and then we'll come back to you to introduce yourself. Okay. Remember where you were, Dr. Norchasm?
Yeah. Welcome on board, Sarah. So that FDA hearing was a real turning point, and as you recall, the panel was stacked up with a lot of GYNs and industry advocates, and it really was. I think that the turning point came when Dr. Craig Shriver, who is a surgical oncologist at Walter Reed Medical Center, essentially just said, look, this is just a florid violation of safe surgical practice. And I think that statement really just turned the entire panel upside down. And after that, the bioethicists started to fall in line, and even I think some of the GYN oncologists started to have to sort of fess up that this is a problem. And then immediately after the hearing, you'll recall J&J pulled the device off the market, which was a pretty massive win. They voluntarily did that. Unfortunately, Karl Storz has not done that yet, and they now remain the largest manufacturer of this. And FDA eventually ended up issuing this guidance, I guess. They fell short of a ban because I think the GYNs ultimately were able to convince the FDA that this is a matter of a trade-off equation. That is, the morbidities associated with morsellation, which include larger incision sizes, wound infections, maybe a little bit higher incidence of DVTs and wound problems, are comparable risks to upstaging a contained stage 1 cancer to stage 4 cancer, which is which is a vastly unethical comparison. I mean, you're comparing apples to oranges. But irrespective, I think they were able to convince the FDA that this is a trade-off. And unfortunately, they had some very heavy-duty supporters. If you recall, the New England Journal of Medicine published an opinion piece by Dr. Lisa Rosenbaum, where essentially they pointed the finger at this whole effort and called this N of one policymaking, meaning that it was an N of one that caused this whole change, which was nothing could be further from the truth. I mean, we had all the data in front of them, right? So I think in the end, it sort of points to sort of a cognitive defect in the way our system is set up in general, frankly, where, again, this the whole thing goes back to the idea of not benefiting or getting harmed. How do you balance this? And fundamentally, I don't think as a society we've been able to figure out how to ethically balance majority benefit with minority harm. And that's what this is. I mean, this is like, there are other examples of this all over our society. I mean, I don't mean to get too philosophical, but I think it's just sort of the way our system and our culture is set up. And, it's tempting to go down the path of saying, oh, the FDA is corrupt. I don't necessarily think it's corruption. I think it's just, I think it's a cultural defect, for lack of a better term, that we need to wrap our heads around. And there are other manifestations of it going on around us all the time. That's sort of why I think they weren't able to do the right thing. So I can't hear you. I'm sorry.
I muted myself because my dogs were barking. Sarah, let's have Sarah introduce herself and tell us a little bit about your morsellation story.
All right. Okay. So I'm a physician assistant. Wow, I can see myself. That's weird. And back in, actually probably since maybe 2010, I was having problems with abnormal bleeding, and things got worse with time. And then I had quite a bit of pain, and I finally did go to the GYN at the place that I was working. I was working at Kaiser, and I saw like 3 doctors. Initially, I saw one doctor. I knew that I was going to need to get some testing, like an endometrial biopsy with all the bleeding. So I basically set up one appointment to do everything. And I sort of orchestrated, I guess, what needed to be done. So I had the endometrial biopsy. I mentioned that perhaps I should be tested for anemia, and I was very, very anemic, and I was having so much pain that I couldn't even sit down. The only way I could sit was on the edge of a chair. It's almost like as if I was 8 or 9 months pregnant. So I went to go see a doctor, and I asked them also for an ultrasound. She thought I had a fibroid. The ultrasound came back with 3 fibroids, but the only thing she was interested in was the fact that my ovary looked a little bit enlarged, had a cyst. And so she said, okay, well, let's do one in a month. And I did one in a month. And she basically said, oh, the cyst went away, everything is fine. And I looked at the ultrasounds in detail. And basically I found that I had 3 fibroids, and comparing the 2 ultrasounds, I had 2 fibroids that actually decreased in size, and the other fibroid more than doubled in diameter within 4 weeks. So that was like a red alert for me. I mean, I knew I was perimenopausal, but I thought to myself, this is crazy. If it's a hormonal problem, why wouldn't all the fibroids increase in size? And I tried to explain this, and I explained it to 3 different doctors, and they just said, oh, I don't think that's anything. And when I finally got referred to the surgeon, the GYN surgeon, basically what he said, he just didn't believe anything was wrong. I asked him for an open surgery. Now, as a physician assistant, one that worked in surgery, one of the things that you do in an informed consent is you have to mention everything that you want, all the possibilities, and then have the patient choose. So it was actually a crime for him to tell me that I did not qualify for an open surgery like I requested. I was bleeding so much. I had so much pain. I was in a brand new job, and I was working really hard because they needed the other physicians and PAs that I worked with needed to take vacations that were like 1 year. They've been waiting for a year to do this, and when I got hired, they just let me basically take care of most of the clinic work. And so I was in a really difficult situation. I thought I consulted 3 doctors. I considered going outside of Kaiser, but I thought, there's no way I could afford something if something went wrong. So I stayed within the Kaiser system. I begged my doctor right before I had surgery to open me up. And then I told him, if there's any problem at all, please, tell me you're going to give me an open surgery. So in the surgical room at that time, he was trying a brand new morcellator. In fact, he was trying to woo me with this morcellator about how great it was and how the blades were so much sharper and the pieces were going to be, much bigger. It wouldn't be ground up really. And so he allowed the salespeople to be in the room. They had to be in order for him to try this new morcellator that he thought was so cool. I was supposed to be in surgery for about 45 minutes. I was in surgery for almost 4 times that long. And when he came out, I remember him saying, it was a really difficult laparoscopic surgery because this fibroid was near the main vessels, but I was successful in getting everything out, and everything is great. You don't have to worry anymore. This is what he told me. So, so basically I was morcellated. That probably the largest fibroid was the one that was the LMS that was diagnosed. He called me 2 weeks after my surgery to tell me that I had, that first of all, I shouldn't worry about this diagnosis. But he said that the pathology said that I had leiomyosarcoma. Well, as soon as I heard that, I thought, man, I'm in trouble. And then I said to him right away, I said, hey, look, then, why did you morcellate me? That's crazy. And then he said something really idiotic, like, well, if I knew you had cancer, I wouldn't have morcellated you. That was his apology to me. Anyway, so I've now, since 2002, I have been, I was really lucky to have the hormonal therapy control my metastasis of my tumor. But it did metastasize after 4 years. And since that time, it's been about 3 years, and I've been fighting really hard. I've had, as you mentioned, 13 surgeries in the last 3 years. And I've had all the immunotherapy drugs, and that it didn't seem to do anything for me. And the chemotherapy, and I'm still trying some of the old chemos to see if anything will control my tumor. So that's where I'm at. That's my story.
Okay, thank you.
I did go, I have to say, I did go right away, actually, after I started back at work. You know, they give you 4 weeks off. And I started back at work. And the first thing I did was I contacted the chief of staff at Kaiser and the CEO. And I didn't get a response. So I actually walked into the chief of staff's office. She happened to be an OBGYN. So it was in the same clinic area where I was treated. And I came with a whole bunch of journals, medical journals, talking about morsellation and talking about sarcoma. And I approached her in a way that I thought that I needed to teach or to make her aware of this. And I gave her the journals. And I said, please, you know, take a look at this. Kaiser, you could do something incredible for Kaiser. When I found that she just threw the journals on the ground. And she said, well, you know, I'll have to really look at these. They're often very biased. So at that point, I said to her, well, you know, Kaiser can be the first one to really show that they care about their patients by banning morsellation here. Of course, that didn't happen. In fact, what happened was that their clinic bought 2 more morcellators after I was diagnosed.
Oh,
So
that is just infuriating.
It
Just
was
infuriating.
Yes.
Yeah.
So I tried to actually sue Kaiser, but after many depositions, I just found that they were lying about everything. The doctor said he offered me an open surgery and I didn't want it.
Oh gosh. Okay, we're going to come back to suing. That's one of my questions. And that's just a tremendous story. I'm sure there's many people in the audience who the same thing similar has happened, and I'm sure the chat box is going to be full with stories. But for now, I want to go back to the black box warning, and I want to ask the panel, do you think it's being followed? What was it? And do you think it's being followed today?
So go ahead.
I just give my opinion. I think it's really probably fairly split between different factions of gynecologists and how they are interpreting the black box. I mean, I don't know how many of you saw there was a Wall Street Journal follow-up article, I think in either 2019 or 2017, that basically was polling doctors about this and whether they were still using it. And some doctors would literally say, would be telling their patients in the informed consent process, the FDA is wrong. The FDA is flat out wrong. We don't agree with them. And here's what I think about the device. And that's what that article was quoting. And that's really what I believe. I believe there are a group of gynecologists, a fraction of gynecologists who are still out there who fundamentally don't believe what the FDA did was correct. And they are telling their patients as much informed consent processes or just not making them aware of the risks. I think there's another fraction of gynecologists who are, while they may not agree with it, are taking the responsible steps and making their patients more aware or transitioning to safer methods. So I think it's definitely taken effect in a percentage, but not an overwhelming percentage of gynecologists.
What was the black box warning for everybody to refresh our memories?
Go ahead.
Yeah, so do you want me to take that, Sharon?
Sure.
Anybody?
So look, the black box warning essentially warned against the use of uncontained power morsellation, and the vast majority of women was the language that was used, if you recall. And then, the gynecologists fought a little bit, not a little bit, a lot, and FDA came back and reevaluated the analysis, and they reiterated their warning and the black box. And essentially, the idea was that they should not be using uncontained power morsellation in the vast majority of women. In terms of what effect that had, I think it really, there are two camps. in one category, you have hospitals which are more centralized, and they have a sort of a very robust risk management system where the lawyers are essentially telling the GYNs that they can't use this device anymore. And so those hospitals are, hospitals like major academic medical centers, essentially for the most part, laparoscopic power morcellation has disappeared from those institutions, and mostly they're relying on manual morcellation, or if they use the laparoscopic power morcellator, they put the specimen in a bag before they morcellate. And then you have smaller individual practices which essentially work with hospitals on a contract basis, and those practitioners have a lot more freedom. So they really are subcontractors for the hospitals, or they subcontract with the hospital and they use their facilities. So they have a lot more freedom in terms of what they want to do, and they rely mostly on informed consent. But really, I mean, it was a pretty seismic shift in their thinking about morcellation in the gynecology field. But I think a vast majority of gynecologists are still relying either on laparoscopic power morcellation in a contained fashion or manual morcellation. And unfortunately, I really think that the solution is going to come from the judiciary in terms of giving market feedback to these practitioners, because I don't think they're self-regulating, frankly.
I think so too. So let's talk about informed consent for a minute.
Excuse me?
Do you want to add something, Sarah?
Add a little something? Is that okay, Sharon? I
have to mute myself because of my dogs.
Okay, all right.
Go ahead.
Okay, so what I did want to mention was that in 2014, not only was it that it wasn't supposed to be the majority of women that were supposed to be morcellated, and at the time there was no containment issue in 2014 when they put out that cautionary decree. But they also contraindicated using the morcellator in perimenopausal and in menopausal women. So that was the original decree by the FDA. But recently, and it was earlier this year, that Dr. Shuren relaxed that decree. What he did was, first of all, he said, he added the part where it needs to be contained. But the part that really relaxed this issue, and I'm afraid that the power morcellator is going to continue now. The market is definitely pushing it. But they relaxed it to say it's not to be used in women 50 and older. Well, the problem with that is that there are so many women between the ages of 40 and 60 that get this. And between 40 and 50, the percentage of women who have LMS compared to their 50s is nearly almost the same. It's just slightly less. So this is where we're going to have problems, like with Amy Reed. She was 40. There are a lot of 40-year-olds, and I'm sure you're aware, Sharon.
Thank you for adding that information. Yeah, thank you. So I'm going to go back to informed consent. Do women now get better information from their doctors in full disclosure before they consent to laparoscopic morcellation? What do you think? Anybody?
I think it's similar to the black box answer that I gave, in that it's going to vary from doctor to doctor. I mean, the FDA, I don't think with the black box warning, the FDA did not set any standard or any requirement for the informed consent process as it relates to morcellation. So what they did essentially is they left not only whether to morcellate, but what to say in these conversations with patients. They left that completely up to the discretion of the doctors. So, and that was a discussion at the FDA hearing. I mean, they sat around and actually posed this question as to, if we make this a black box warning, how does that get back to the patient? And a lot of them actually had a struggle answering that question. They said, well, Is that something that's presented to the patient in the room? They show them the black box warning and say, no, not exactly. It's not. So it is, I think certainly there's a lot more publicly available information for women, and doctors will be more sure to drive home the point, to at least mention the risk in some capacity in those discussions to protect themselves. But I also think that you still have doctors who, like I pointed out in that example in the Wall Street Journal article, who are telling the patients what they want to tell them about the morcellator and promoting the morcellator, downplaying the risks. And that's really on a doctor-to-doctor basis. It's really going to vary. There's not a standard, I don't think, for what informed consent information is presented. So we really hope that's what's presented, but it's not standardized at this point.
Dr. Dorchester?
Yeah, if I could add to that. So there's this notion that informed consent will somehow magically protect these patients who are susceptible to having their uterine LMS diagnoses missed. Somehow informed consent will magically protect these patients from upstaging by morcellation. This is a complete falsehood. Informed consent's not a patient safety device. It's essentially a legal liability mechanism for physicians to have their rear ends covered when they actually do harm a patient. So the idea that informed consent somehow could justify missing someone's diagnosis and then subjecting it to an upstaging is just completely absurd. And frankly, I think just the fact that our system, either at the FDA level or at the level of medical practice, is willing to use informed consent as a substitute for patient safety sort of thinking along good practice and safe practice speaks volumes to what the actual objective of the system is. The actual objective is to sustain high volumes and to sell something that sells well. And so, we, as you recall, we had one of the experts on mandated disclosure was a lawyer from the University of Chicago who submitted a letter to the FDA on behalf of our effort, and we read it at the FDA hearing, and essentially debunked this idea that from a legal perspective, informed consent would serve a safety function. It just doesn't. And frankly, even from a legal perspective, I think it's just an absurd argument. And I think any court that hears this argument will reject it ultimately. Unfortunately, no courts have heard this argument yet. And maybe one day a court will hear this argument and reject it. So.
It leads me to another question, Sarah and Dr. Norchasm. If a woman is now morcellated and it turns out to have uterine cancer, can she sue her doctor and win?
So I wanted to add a little something to the other one, if I could.
Sure.
So during, can you repeat that question, actually, the actual question?
The last one I had?
The one before.
Oh, the one before. So informed consent, do women now get a better information from their doctors and full disclosure?
Yeah.
Before they consent.
The problem is that with informed consent, you're going to have quite a few things listed. They're going to say, it could cause bowel perforation. It could cause problems with the ureter. Could cause it can cause any problems nearby where the surgical field is. And then they add, and there's a very rare chance that there's cancer. And if most GYNs are always very reassuring, especially if they have delivered a child before. And so they'll just say, oh, but that's not, you don't really, I don't believe that you have any problem there. So they can say whatever they want. And they can reassure you with this informed consent. But I can tell you, I'd like to actually reveal something that Kaiser did about this whole idea of morsellation. I got some inside information after I had left Kaiser, and there was a paper that was roaming around to all the radiologists, and basically it said to them, if you see a fibroid or a mass in the uterus, you are not to say you cannot rule out cancer. Do not say that, and do not recommend any other testing like an MRI. So this is what Kaiser gave out to all their radiologists, so that everything could be just kind of vague, instead of having the radiologist saying, this may be, it's showing some signs that it might be malignant. Maybe we should test more. None of that is going on. So in terms of informed consent, at Kaiser now, you're not going to get a good radiologist reading. Sorry.
Okay. Did you want to add to that, Sarah, or are you done?
I think someone else right now.
Okay. I'll go on to my next question, which I started. So if a woman is morcellated now and turns out to have uterine cancer, can she sue and win? Anybody can answer that. What do you think, Dr. Norchasm?
So the answer to that, the short answer to that question, Sharon, is I don't know, because there have been no cases brought against practitioners that have gone to trial yet. And in fact, the vast majority of the cases against the morsellation events have been against the medical device manufacturers, including Johnson & Johnson, Karl Storz. I think the bar for demonstrating malpractice is a breach of standard is typically in most states that's the bar, and that's it's a somewhat challenging bar to surpass, because the GYN associations have essentially come out and sort of, in one form or another, endorsed this practice. And so, now there is such a thing as applying an existing standard incorrectly to someone. So in other words, if a patient has concerning features, or there are problems with their imaging, with their clinical presentation, and an assumption of benignity is made, and morsellation happens, that could be a claim where, yes, there standards exist, but if you incorrectly apply a standard, then that's a different thing. But on the flip side of it also is actually the legal argument that this practice intrinsically is negligent. So in other words, if you have a tumor that's potentially malignant and you have no way of knowing whether it's malignant or not, and you're not willing to biopsy it, and you're not willing to apply any sort of reasonable oncological measure to risk stratify it, and you go ahead and perform a floridly oncologically unsafe operation on it, which mincing up a tumor is by definition, then that sort of meets the English common law definition of negligence, right? And so you put that in front of any court, that should work. But the problem is most medical malpractice lawyers work on, they don't work like defense attorneys where they get paid by the hour. They work on contingency. So every time they take on a case, they're taking on risk. So they put time in up front, and they're not going to get paid until they win. So the risk tolerance for medical malpractice, there's this, outlandish notion that there are all these these predator med mal lawyers out there that they sell to physicians like me throughout our education, that these medical malpractice lawyers are these demons out there who sue, and that's what the problem is in the system. The reality is that the bar for medical malpractice is extremely high. The vast majority of medical malpractice cases lose, and the plaintiff's attorneys are actually taking on risk when they take on a case because they don't get paid until they win. So there's a lot of resistance to bringing these cases on. And you can see, I mean, you can talk to a lot of your constituents who have tried to sue. The vast majority of them, of these lawsuits, are against the medical device companies and not against the practitioners for that reason. So, you know, in the end, I don't know what the real solution is. I think, you know, it's going to have to, at some level, come from the court system, but I don't know what that case is going to be that's going to break this. We'll have to wait and see.
Sarah, now you sued. What was your outcome?
Well, I actually sued both the Kaiser, you know, like again, I mentioned, it was criminal for them to not allow me to have an open procedure when I asked for it. And when I told them I was worried about malignancy, and he specifically told me, you do not have cancer, you don't qualify. So I sued Kaiser, but it's like I mentioned, the lawyers basically tell the doctors to lie. And if in the deposition they are lying, it's, you know, word against word, and there's nothing written in the notes that I asked for an open procedure. So that didn't really go anywhere.
Your doctor just denied that you asked that for an open procedure.
I'm sorry?
So your doctor just denied the allegation that you asked for an open procedure, and he denied you.
That's correct.
Yeah.
And he also said, you know, that I told him I didn't want an open procedure. So he really extended that lie. And as soon as that happened, basically my lawyer wasn't that interested anymore in following through, because he couldn't really get, you know, anything that was concrete.
Right.
Couldn't get the truth, basically.
You couldn't get any money out of it probably either.
Right. He didn't want to do it because it was going to be time consuming and it probably wouldn't make money. I actually had to pay this lawyer a little bit. He agreed, you know, if I would start paying him at like $5,000. But then he basically said, you know, I can't continue this. As far as the manufacturer goes, now this was an interesting part because I tried to basically say, hey, to the manufacturer, you have made something and you have allowed GYNs to use it. And it's really the concept of mincing up a mass is essentially, you know, not correct, right? In the medical field, you just don't do it. So therefore, I was trying to explain that's a problem. You don't put out a medical device that can cause harm. But I was basically told that, well, you know, they can say then that it was the doctor's fault, and it was malpractice. He decided to use it, and so that's where there's a question, you know, what's going on. Mm-hmm. Unfortunately, I was forced into a settlement. I was feeling really bad, and I even said to the mediator, I need to go home now. I can come back tomorrow. And she said, no, you can't, which I don't think was right. I mean, I really feel like she forced it. I said, I do not feel well. I'm in a lot of pain. I need to go home. And she wouldn't allow it.
Okay. Aggravating again, infuriating. I have a quick question for both Sarah and Dr. Norchesm before we take some audience questions. Sarah, what advice would you give a woman who has problematic fibroids? Briefly.
Mhm. Basically, I would tell her that she needs to have someone there. This is where I made a mistake. I didn't bring a friend or a sister along during the surgical consult. So basically there were no witnesses. And that person should help ask questions, because it's difficult when you're in a situation where your body is really giving you problems to have any kind of quality of life. So that's good to have that person to also ask questions. But the big part is, with fibroids, you should always ask for surgery where they're going to take it out, the uterus out, or you should never do a myomectomy, because that also can spread cancer if it's cancerous. But if you take the uterus, it needs to be taken out in full. Do not cut it. Do not scrape it. Be gentle with it. And the doctor has to understand, that and be, on your side. So if you get a doctor that doesn't want to do it, go somewhere else.
Great, thank you. How about you, Dr. Norchesm? What would you tell a woman who has problematic fibroids? Oh, you're muted. You're muted right now, Dr. Norchesm.
There we go. He's on.
Okay, there you go.
Thanks, Kyle. So I think basically what Sarah said, I would echo that. I think the fundamental question, what it comes down to, is whether the woman in question with symptomatic fibroid tumors is planning on having a family any further or not. I think that's sort of the fundamental sort of branch point. If the woman is looking to have a myomectomy, which is by definition a non-oncological operation, which increases it poses the chance of spreading an undetected or undiagnosed cancer, then I think the fundamental issue, and I think the cutting edge of this field, is how do you preoperatively diagnose these tumors? And why is it that gynecologists are the only specialty in surgery that fail to preoperatively biopsy these tumors, either in a preoperative setting or intraoperatively? Both of those settings provide an opportunity for biopsying tumors, especially if you're going to do a uterine sparing operation. At the present moment, I think if a woman does not want to have any further children, I think every woman should demand to have an en bloc resection, like Sarah mentioned. That's the safest thing to do right now. There are gynecologists I know who have started to perform biopsies of these tumors. Certainly in the case of high-grade leiomyosarcomas, when your mitoses are above 20 per 10 high power field, even on frozen section, you are able to see that there's concern for a malignancy literally intraoperatively. So the surgeon is standing there, they take a couple of core needle biopsies, and with over 20 mitoses per 10 high power field, it is possible to diagnose prior to doing any sort of non-oncological operation. So really, I think like the way to think about it is, are you going to have any more kids or not? If you're not going to have any more kids, then you're going down the path of a full uterine resection. And in that case, it's well within your right as a patient to request that an en bloc resection be done. And if the surgeon's unwilling to do it, you move on to the next surgeon. There are good surgeons, good gynecologists out there who are willing to do a safe operation and understand this problem. But I do think that the cutting edge of what we all should be focused on is how to really obtain tissue biopsy before any sort of non-oncological operations performed. Really, if you think about it, even if morsellation was abolished completely, you still have women who have fibroids and who want to retain their fertility. And the myomectomy operation itself is a non-oncological operation. You have to cut into the uterine corpus, you have to scoop out the tumor, and then you have to get it out of the incision. Those all provide opportunities for cancer to spread. So really, we're still back to square one, even if morcellation is abolished, which it's not, obviously. But really, the question is how do we convince these GYNs to start using standard tissue biopsy, which is what all surgeons do. It's very striking. Everyone should really sort of take stock in this. The uterine fibroid tumor is the only tumor in the human body that has malignant potential, but is not subjected to routine biopsy. The question is why? I mean, why? I mean, it really, like, from a surgical perspective, it baffles my mind. It baffles the minds of many non-gynecological surgeons, frankly. So I don't know if I answered that question, but really, I think I would suggest for women who want to have full uterine resections to go down the path of en bloc resection and demand it, and women who want to have myomectomies to request that the tumor be biopsied before any sort of non-oncological procedure is performed.
Thanks. Sarah, you have anything to add to that?
I do. I mean, no, go ahead. Go ahead to the next question. Thank you.
And Kyle.
Yeah, I'll just say something really quickly. I mean, Human just, used the word demand en bloc resection. And I think that's, patients taking more independence in these informed consent discussions is really, really important. It's a very difficult thing to do, to go against the word of your doctor, because patients have so much trust in them. And what we saw in so many cases, and in the film specifically, in these patient-doctor dynamics, is the immense trust that patients have in the doctor. And to go in and, against, even in some cases, their wishes, to override them and say, no, I want this procedure. It's a difficult thing to do, but I think it's important for people to do it when someone is pushing a minimally invasive surgery that they're not comfortable with. And we've seen cases, I was interviewing one of the families who said, "Oh, we told our friend about it. They went in, they demanded this open procedure, and they later found out that they had a cancer in there." So while it's difficult to do, I think patients having their voices heard and being a little bit more assertive, even in a dynamic that they're not used to being assertive in, can really help people, and in some cases save their life if someone is pushing a minimally invasive a morsellation procedure.
Great, thank you. I'm going to take a couple questions. Some were sent to me. One is from Marge, and her question is the doctor making the decision to morsellate, or is it the insurance company making that decision? Anybody?
So, I think that well, if I go back to 2014, when some hospitals were decided not to morsellate, I remember it was the insurance companies that would basically not give the okay. A lot of these HMOs, especially, they have to give like a referral, and get the okay from the insurance company to pay for the surgery. So it was interesting that it was the insurance companies that brought this to light. But really, I believe that there's the hospital. A lot of hospitals, even though they may say they are nonprofit, they have administrators, and those administrators are usually paid very, very well. And sometimes they push certain procedures because they're more efficient and more cost effective. So I could say that doctors sometimes are pushed to try to do this procedure. I mean, they're pushed in a way that probably a situation where they would not get a certain bonus if they didn't do a number of these particular procedures. At least at Kaiser, is the way it worked. So industry, I think industry is colluding with the administrators in the hospitals. And I think also the GYN societies, especially AAGL, the Laparoscopic Society, they're all trying to, they've been in this boat together for a long time. So I believe something is going on. Some of these people, certain people are getting paid off, and they're trying to prevent, the ban of morcellator, which, by the way, I actually believe we really should ban the morcellator. Back in 2013, there was a Kaiser study that they released in Southern California, and it basically said that out of all surgeries, hysterectomies, 1 in 67 women will have some kind of cancer. And we all know that with any cancer, if you spread it and make it stage 4, your diagnosis is pretty bad. So we're talking about things like endometrial cancer, cervical cancer, other adenomas, other types of tumors. So 1 out of 67.
Yeah, it's a lot.
Shocking.
Yeah, I'm glad we brought up other cancers, because it's not just a uterine LMS situation. It's other sarcomas and other cancers too. I'm getting in the chat box a lot of questions and comments about biopsy, Dr. Nordchasm. A few were saying, my wife, LMS was missed. They did a biopsy and they missed it. Another one wants to know, what's the likelihood the occult section is missed, and doesn't a biopsy risk reseeding the cancer as well?
Yeah, so these are all great questions. Can you hear me okay? I wanted to specifically address this because, so first of all, I think it's important to understand that a lot of gynecologists tend to very superficially conflate the idea of biopsy by claiming that, oh yes, we biopsied. Usually what they're referring to is an endometrial biopsy. So the vast majority of gynecologists are not biopsying the actual fibroid tumor. So when they say, oh, we biopsied, they're usually referring to an endometrial biopsy, which does not give you a diagnosis of uterine LMS. Uterine LMS is a soft tissue sarcoma that originates in the myometrium. It's distinct from the endometrium. That would sort of be like saying, oh, someone has a brain tumor, I biopsied their scalp and there was no tumor there. Well, that's not where the tumor is. The tumor is in the myometrium, not in the endometrium. So I think a lot of patients get confused because they believe that the gynecologist did a biopsy. Well, they did a biopsy, but it wasn't the biopsy of the actual tumor. So what we're talking about specifically is the biopsy of the tumor. With respect to the question of whether there could be a chance of spread from the biopsy itself, there is, of course, this notion that there's a needle track spread. So in other words, you take a core needle biopsy and you insert it into the tumor and you pull it out with a chunk of the tumor in it. And there's a theoretical risk, although it's a pretty small risk, that if there is cancer there, you've pulled the cancer out with you. But I would just ask the questioner to consider what we're talking about. Let's say there is no cancer there. Well, when you do that, there's no risk of cancer spread. There was no cancer there. But let's say there is a cancer there, right? And you don't do that. And then you proceed with morcellating. Well, which is worse? Is taking basically the equivalent of a meat grinder and grinding up a known cancer better than inserting a needle in a controlled fashion where there's a very, very small chance of that cancer, being spread? The answer to most reasonable folks is, well, you take the chance of that needle track, spread over the chances of spreading the entire thing through an explosion, which is morsellation, basically. And in fact, this is a risk that most surgeons take. I mean, it's, most other surgical specialties, thoracic surgeons, general surgeons, when they biopsy a mass, there's always a risk that's discussed with the patient, but the risk is exceptionally small. On the flip side of it is if you don't have tissue diagnosis and you actually subject the patient to either non-treatment, meaning you ignore the problem, or you then do a non-oncological operation, the risk of catastrophe is like log scales higher. So the idea of needle track spread is something that a lot of gynecologists have sort of conflated to defend their position of why they're not biopsying. And then the third question was regarding the sampling error. Look, there's always sampling error in any biopsy, right? So for example, as a thoracic surgeon, patients come in with something called a Barrett's esophagus, which is a precancerous lesion of the esophagus. What the thoracic surgeon does is they do a 4-quadrant biopsy of the esophagus around the area of Barrett's, right? And the rationale there is that you're establishing a statistical level of certainty for a tissue diagnosis. It's not going to be 100% sensitive. But look, here's the issue. Even if you have a sampling bias, think about what the sample bias is if you don't do a biopsy. You have a 0% chance of picking anything up versus, let's say, an 80 to 90% chance if you do biopsy. The idea here is establishing a reasonable assurance of benignity. And what that means is that you've made good effort to obtain tissue biopsy. If you don't make any effort, then you haven't made any effort. You've just exposed the patient to Russian roulette. This is a concept that's really missed on gynecologists. And it's actually a really shocking sort of manifestation of the very sort of siloed education that gynecologists receive. And the gynecologists essentially train away from all other surgeons, because I can tell you, the vast majority of non-gynecological surgeons look at this idea that gynecologists don't use tissue biopsy on a potentially malignant tumor, and jaws drop. And the feeling is this is completely an absurd thing to do. Yet, look, it's a specialty that operates in its own silo. It doesn't have any regulation from the outside. And so they're doing what they're doing. They're not biopsying these tumors. And that's a catastrophic error, So, we sort of keep moving on in time, but that's the problem.
Thank you. I have another question. This is by...
respond a little bit?
Yes, you may. Sorry.
Yeah, okay. I just wanted to put in that I would, first of all, I want a morcellator banned. As you know, 1 in 67 women having cancer when they're having, hysterectomy, that's huge. So, but who knows if we could succeed in that? It's very difficult. The FDA never really has banned devices. They go with these black boxes, which the patient never sees. So what I wanted to say was that I would agree to biopsying if it was intraoperative, right before you're going to decide if you're morcellating or not. That I would agree to that, because when you think about a core biopsy, it's considerably, it's not tiny. Basically a pencil eraser, maybe it's the width of that. If you think about that, that has billions of cells in it. And to retrieve something like that and then bring it out through tissue again with any kind of resistance, I do feel that could spread it. Why take that risk? But intraoperatively, I would.
So I'm just thinking in my mind, if they do a biopsy and it is cancerous, then they would be taking that whole uterus out anyhow once they discovered that information, right? So the fact that uterus might have been seeded, but it's all going out in block, may be the answer to that problem. I don't know. Just a thought. I'm not a doctor.
I'm sorry. So Karen, Sharon, I'm confused about what you're mentioning, what you're talking about. So you're saying that if the biopsy is positive, then you'll proceed with an oncological resection.
Yes.
Which is the goal of tissue biopsy, right?
Yes.
If the tissue is negative, then there's your reasonable assurance of benignity, and And again, I mean, yes, there is a possibility. No biopsy is 100% sensitive. There's no surgical or medical biopsy technique that is 100% sensitive. So yeah, I
Right.
mean,
There's
look,
also, sorry, there's also usually multiple fibroids in there. So I don't trust always the gynecologist to sample all of them. I don't know.
well, look,
There's
yeah,
an-
look, that's the issue. The issue is it's a sampling issue, right? And that is the case with, as I mentioned, the closest example that I could think of is the Barrett's esophagus that thoracic surgeons manage. And again, that's sort of where you have a ring of inflammation around the esophagus, and you don't know where the precancerous lesion could be. And so what we do is we do 4-quadrant biopsies, right? And so essentially you sample, right? And so when you do a sample, you decrease the sampling error, right? And so whether this is done intraoperatively or preoperatively really has to do with the anatomy. I mean, you can envision scenarios where a tumor is subserosal and not accessible with CT guided biopsy because bowel's in front of it, well, you can't biopsy that. But if there's something that's sort of subendometrial and you could do it through a hysteroscope, those are all technical things that both good gynecologists and good radiologists could assess. Certainly, if it's not possible to access the tumor, then you do it intraoperatively. And I can tell you, like my wife's ULMS had about 40 mitoses per 10 high power field. You will be able to see that on an intraoperative frozen section. There's no question you could see that. Any reasonable pathologist would say that if you have 40 mitoses per 10 high power field, you will pick that up even on a frozen section intraoperatively. So the notion that there's resistance to this idea on the part of the gynecologists is just floridly absurd.
Okay, thank you, both of you. Thank you very much. I've got a question from Tina. She's a mom with 2 wonderful boys and 1 with special needs. She says, although my initial surgery to remove the mass was not purposely morcellated, it broke into several pieces on removal. Now the cancer is spread in my peritoneal sac with 10 to 11 masses. After 3 doctors and 2 second opinions, we're looking for a third opinion as the prognosis has been deemed hopeless. I can't fathom leaving my children. Do you feel there's any hope for me? Anybody can answer that. That's a hard one, right? Stumper.
Yeah.
This is exactly what I'm kind of dealing with. I keep getting tumors in my peritoneal cavity, and I have dealt with it by doing the surgeries. The first thing you should do with LMS is take it out, remove it. That's the best way, because a lot of the chemos, even though they may be 30% effective in the big population, they don't work for 70% of the people. So I would first try to get clear margins as much as you can and remove tumors. Find a surgeon who can do it.
This brings up, Dr. Norchasm, the sugar baker technique for people who are just diagnosed. Do you want to talk about that?
Sure. Yeah. First of all, was it Tina that you said? Yeah. So Tina, I'm sorry that it's such a cliche to say that I'm sorry, but that you're going through this. But I mean, first of all, I sort of I know exactly what you are feeling and going through. I would say, with respect to hope, hope is something that is sort of a construct that we create. Amy was extremely hopeful up until the last day of her life, and that was because she valued the time, and she took the day and the moment as moments as they came. And and I think it's easy for me to sit here and say this to you. You're going through this, and better. Most people who are on this forum right now probably have a better grasp of it than I could ever relate to, even though I observed it in what my wife went through. But the idea of hope is sort of the concept of living in the moment and recognizing that time is something that we get to control what we package into. What we package into our time is what creates hope. So that's the first thing. The second thing is I agree with Sharon that this disease is one where tumors keep popping up, and some of these tumors will be in life-threatening places anatomically. And so yes, there's a combination of chemotherapeutic approaches, but as we all know, chemo eventually sort of has its limitations in terms of controlling these tumors. And so you're left with the idea of resecting them. And so, the strategy that Amy used after she essentially failed medical management with chemotherapy was to triage the tumors as they came up in terms of how risky they were, and resect them or radiate them, ablate them, whatever the strategy was. And I think that did make a big difference, given the aggressiveness of her tumor histologically, as well as the fact that it had been spread by morcellation. Amy had a survival that was quite remarkable for what had happened to her. And again, it had to do with resecting the masses as much as possible on the front end early, and then ablating them as they came up, or resecting them. So with respect to the Sugarbaker operation, I do think that it depends on how quickly you catch this disease. Several women have actually had Dr. Sugarbaker's operation, and that entails essentially doing a full peritonectomy and a cytoreduction followed by heated intraoperative chemotherapy. I know, for example, Meredith Hammond is an example of a woman who had a very early stage operation and had this HIPEC operation, and she has no evidence of disease like 7 years later. But then there are other women who had Dr. Sugarbaker's operation, and they had more advanced disease, and it was sort of gone. But I think Dr. Sugarbaker will probably state that it depends on how quickly you catch this after morcellation and how much the disease has spread on the peritoneal cavity. But it certainly is an option. I don't think any oncologist would say there are clinical trials that demonstrate better efficacy, but I do think that it's a reasonable thing to consider. So. You're muted.
I have time for one more question, and it's mine, but it certainly has come up in the chat box over and over. How can this film, and Kyle, you might want to answer this, how anybody can answer it, how can this film be used to educate women and the medical professionals? Who needs to see it, and how do we get the film to them?
Well, I think number one, in terms of how it can help women, it can help women by, I think the biggest thing is just giving them the best form of informed consent that you could give anybody, right? Which is not leaving anything out, showing you what the worst case scenario of this procedure is, because that's what's left out. Even if a woman is informed about the risk of the procedure, something that isn't really highlighted is the magnitude of risk. It's going further in that conversation. If you are this 1 in 350, what exactly does that mean for you? And what it means is you could potentially have your cancer upstage from stage 1 to stage 4 and be given basically a death sentence. So that is a picture that is not presented, and it's not presented certainly viscerally in an informed consent discussion where you're just kind of calmly talking about statistics and being reassured that it's not a problem. The film is going to give you, I think, the clearest picture you could possibly get about what that endpoint could look for you if you were to be one of these women. And we can get that to women, I think, most effectively by word of mouth is what I'm very much hoping from this film, is that women tell their extended family and tell their friends. I mean, as much as individual women trust their doctors about how they're going to make healthcare decisions, they trust their friends and their family also. And As I've heard, just women have told me about telling friends going into this procedure, ask for an open procedure, ask for a less invasive procedure. That's meaningful. I mean, even though they aren't medical experts, when you know someone that closely as your friend or your family, you trust them. And so getting the word out just person to person that way, I think can be very, very valuable. I'm pushing out the film, marketing the film. It's going to be available on a number of platforms in a couple of months, including Apple TV, Amazon Prime. But in terms of pushing it out, it's going to be those women's health platforms, not making sure women know that this isn't a issue that is exclusive to leiomyosarcoma like we were talking about. It's any of these cancers that can be spread by morsellation. And just, again, increasing the awareness numbers is going to be so important. I saw a study just from last year that showed, it was a survey of the number of women who are aware of this issue. And it was between 8 and 12% of women that they surveyed were aware of power morsellation before having or after having undergone a hysterectomy. So that's incredibly low, and it needs to be brought up. And I think the film can do wonders in terms of word of mouth. The medical community, it's going to be a little bit more difficult because people are going to be pushing back on this. But I think approaching the public health communities and the medical ethics communities first and kind of zeroing in on them is going to be important to help influence the decisions that the other medical individuals are making. But I think if you can find those doctors who are going to have that right kind of interpretation of the film, and it's really going to hit them, the individual stories, they can have a larger influence on their department and their fellow doctors as well. So that's what I think the film can do.
Dr. Norchasm, did you want to add anything to that?
Yeah, let me unmute him.
He's muted again.
There you go.
Yeah, there we go. Thank you, Kyle. So yeah, I mean, I think this film should be viewed by as many physicians as possible. I certainly think it'll be easy for lawyers and law students to view this, and hopefully this will trickle into the legal community easily. I'm continuously struck by how unwilling the AAGL and ACOG have been to engage our community. So I think one could expect in the United from a medical specialty that an organization like the ACOG or the AAGL would actually organization like LMS productive discourse. I think it would be amazing kind of progress if LMSDR or if Kyle's own colleagues could convince the ACOG and the AAGL to show this movie at their next annual meetings, and then have us come in and have a reasonable civil discourse with them. That's how progress is it's considered values. We can engage in discourse and we can solve problems in that way. And unfortunately, the fact that they're unwilling to do this, the fact that ACOG and AAGL are unwilling to engage us in any sort of reasonable discourse, the fact that Kyle had such a difficult time engaging these organizations and finding practitioners to actually comment on this, that itself should tell you something about how captured the whole industry is. And I don't think this is a conspiracy of any sort. I just think it's business and money interests colluding with the need for efficiency and volume and movement that's created a monster. So I don't think it's a conspiracy. I don't think these doctors are evil monsters. I know most of them. They're not evil monsters. They get trained up and they learn how to do something, and they want to be efficient and be fast and reasonable. And when the majority of people benefit, what's better than that? The majority of people already have it, less than one harmed. And so that's how they sort of rationalize it. But really, that's not a deep enough understanding of what happens to people. And I hope that as a result of this film, that the LMSDR leadership, as hopefully other organizations, including Leiomyosarcoma, could actually engage ACOG and AAGL and ask them to please show Kyle Floyd's movie at the next annual meeting of the ACOG and the AAGL. And let's have a discussion. Because this is real. I mean, they now know that this is a scientific and ethical reality. That you take a cancer that you miss a diagnosis on and you morcellate it, you've just given someone a stage 4 cancer. That is an iatrogenic cancer mortality risk that's being caused by the physicians. And so, one option is to ignore it. And that's what they've done so far. I'm hoping that this film will change that.
I'm willing to help any way we can. So maybe we can have a dialogue about this after this. Sarah, do you have anything to add?
Yes, actually I do.
You?
I do. I think that this film should be viewed by all physicians. And the reason I say that is that there are very few physicians in other fields that understand what morsellation is. They've never heard of it. And, there's Human has been very good in getting the word out in the East Coast, but in the West Coast, I'm just shocked, that they have absolutely no idea. As much as I try to, get people to tell their stories on the West Coast, and as much as I tried on my own, it's not. If other doctors knew that this was going on, perhaps there would be more pressure on the GYNs. Because many of these patients have more than just a GYN. They have other doctors. They have their primary doctor, and they may have other doctors that treat them. Yeah. So, and to go further on that is that I think that this film should be shown to medical students, because I think it's important for them to understand where this fits, as Dr. Norchasm mentioned. This is it's an ethical issue. I know that there was actually, when I was morcellated, my oldest son's best friend, was going through medical school, and he didn't see any problem with this morsellation. He just said, she just had bad luck. So, a lot of medical students are taught things, but I don't think there's enough. They have to embrace the fact that they're dealing with human lives, and they have to understand the stories so that they can understand where the breach of ethics occurs.
Well, hopefully Kyle's film, tremendous film, will be out there, and we'll get the word out, and people can also share it with other people, the word of mouth, and doctors to doctors, and we can see what we can do. I also want to say one of the problems is uterine LMS goes undetected, right, until they start slicing into it. We at LMSDR have been funding for the last 4 years the development of a blood test, a liquid biopsy, which can now actually detect uterine LMS from benign fibroids. And this is important research done by Matt Van der Rijn at Stanford University. He's now in his second step of trying this out on thousands of women with fibroids to make sure to be able to take his findings into a clinical trial process. So I just want to remind people, there's a lot of things we can do. We can share this film. You can help support research by making a contribution on our website, lmsdr.org. And let's just get the word out, woman to woman and doctor to doctor. So I want to thank all of you, give a big thanks to our panelists today, Dr. Human Norchasm, Sarah Salem Robinson, for sharing their personal stories with us all. And our gratitude and kudos to director producer Kyle Floyd for 6 years of the work he put into making this important documentary. So thank you all very, very much. And thank you everybody who watched. Thank you. Bye. I'm going to say
thank you, Kyle.
Thank you, guys.
Bye, everybody.
Moderating.
Thank you.
Thank you, Kyle, for all the work that you've done.
Thank you. Thank you, Sarah.
Take care, all.